And when we did these experiments, we also saw that at 5-fold less of the dose, so at 20 mg per kilogram of neo, we were able to see that these mice maintained their function and was almost slightly better than 100 milligrams of Myozyme. So we believe that what we have at the moment, from a preclinical point of view, our new molecule clears glycogen more effectively, and we believe it sustains muscle strength more effectively. And so far we are doing safety studies, and I can say that we have seen no issues to date in the safety studies that we've done with our new molecule. And now I'm just going to quickly pass back to Tim, who's going to tell you a bit more about our clinical development of this next generation approach.
And we're almost done. We just have a few things. I want to assure all the patients here that we will not be adding the rotorod or the barbecue hang test to any of the upcoming Genzyme studies. That is very difficult to do in the clinic, as you can imagine. So Alice is talking about some really amazing results we're seeing in the mouse and in the dish in the lab, and we're very excited about it. Obviously, there's a lot to be done still. If we can get it into the muscle better, if we can target it better, what will that do, though? We know it's not the whole story. We've already talked a lot this morning about dose, about timing, about frequency, about when you would start a patient and what degree of pathology is there before that, along with a number of other things that I think are important. Would we end up seeing better outcomes, more strength, improvements in functional abilities? Or would we maybe see somewhere near the same place, but it would happen earlier? These are questions we can't answer with the data that we have now, but we're positioning ourselves to answer those questions in a number of ways. One is planning, as we have been, to do a clinical trial with this. And doing that in the setting of, we know right now that there is a therapy that for some patients is quite remarkable and for others is not as remarkable. So how do you do this and study a new drug? So obviously we want to study neo-GAA at some point. Part of that pathway to getting to a study that we think is appropriate and safe and going to answer the questions that really must be answered is that we look at some new markers and new ways to study patients with this disease. We all know that a lot of the measures used in this work were used here only in neuromuscular diseases and for the first time. So we've put together a study that's called Embassy that you've heard of. I will let you know that this is for patients that have not started on any treatment yet, and it will get them into a program of about 24 weeks of study. We're going to be looking at them in a new way in regard to imaging with MRI imaging and MR spectroscopy. We're going to be looking at muscle tissue in biopsies as part of the study, and we're going to be looking at a number of different biomarkers. We believe that this data together will help us to better prepare to study neo-GAA and to answer some of the residual questions that we all still have about these therapies as we move forward. So the primary objective is to do that. The secondary objective is to look at these other measures that I think will be very important. And the word biomarker has crept up several times this morning. It's something we talk about every day, and I'm glad that we are moving toward that, but I still think we have some place to go with that. I don't know if we need to say much in regard to summary. I think we've shown you that we do have something interesting here. We think the data is pointing in the right direction, and we're trying to move forward as a partner to you and the community of patients to do that in a way that makes sense and is also safe. And so I just want to say thank you again for having us here. Thank you.
People from Amicus, where are they? Dr. Patel, you want to come over, or Dr. Adera?
Lights.
Any questions? Oh, there you are. Okay, you take the questions.
Lights.
Yeah, take a seat.
Lights.
Lights, please.
Yeah. Yes, sir.
Okay, any questions?
Yes, please.
Question for the Genzyme folks. If the Neo-GAA meets the safety issues, it proves to be effective, and you were to move forward, towards market, would there be a lot of capital changes, manufacturing changes that you have to spend money on to do this, or is the cost kind of in the research side?
You take it. Please stand up. Yeah.
Thank you. Actually, that's one of the good things that we think with our approach to the second generation is the backbone of it is just Myozyme. So from a manufacturing point of view, we're not going to have to change too much. We're only going to have to add a couple of additional steps at the end of the Myozyme process that we have in place to make this new molecule. And I think in terms of, I think everybody here is familiar with the scale up that we had to do with Myozyme and Lumizyme, but we're now in a good place that we would not need to do that again.
Other question? Yes, please. The mic is coming.
So I'm wondering, I saw the uptake curve. This is questions for Allison. It seems that there's increased maximal rate of uptake, and it can't be for the same reasons that Dr. Ling has specified, since it doesn't have that IGF-2. Do you have any ideas why you see this maximal rate of uptake increase with the Neo versus Myozyme?
No.
The rate of uptake,
Yes.
or the uptake?
Yeah, we believe, obviously that experiment, we have muscle cells on the plate, and we believe that really the primary reason why we see better uptake is just through the mannose-6-phosphate receptor. We're just finding it much more effectively and we're internalizing it. I think potentially that we hit a maximal, like a plateau, probably because we saturate the cells at some level, and the cells themselves just can't take up any more enzyme.
Lack of receptors.
Yes.
Dr. Kishnani?
Alison, a quick question. This work really appears to be based on mannose-6-phosphate receptors, and our understanding, at least from clinical work, is there could be a drop-off of these receptors over time. Your work in the mice, have you looked at the young mice versus the older mice, and have you seen a difference?
Yeah, we have. So, we've shown with Myozyme quite clearly, and I think it's been shown multiple times by multiple people, including, I think, gene therapy, that older mice don't respond to treatment as well as younger mice. Whether that is solely related to the M6P receptor declining with age, we don't know, but I think that's probably only a very small piece of it, because I think that the pathology is also progressing in these animals. That autophagy is still, continues to expand in these animals with age. So I think that probably is a big component of that. And I think as well with respect to the decline with age, one of the things I think that hasn't been fully characterised with that is that we know that the M6P receptor drops off dramatically with birth, with it also being the IGF-2 receptor, so the expression of this receptor is very high at birth and then it drops off dramatically. So there might be a case to be made with infants with Pompe disease that this is something, but I think within the late onset population and adults, it's probably not a huge factor.
Dr. Plotz?
Dr. Lang, what do you know about the IGF immunogenicity? You're now going to propose to put in a yet more complicated, immunologically complicated molecule. What do you know so far?
We don't know very much at all so far. We're very early. We have patients treated out at 24 weeks. We're just beginning to gather the antibody data. So it's really
in animals?
In humans. In animals, we know that antibodies are raised. We have not seen any measurable toxicity effect in animals. Could you IGF? So in terms of the immunologic response, I'm responding specifically to your question about immunologic response.
If we could go ahead and wrap it up, feel free to ask questions during lunch. And remember that you will also be able to ask questions during breakfast tomorrow.
There will be an opportunity for questions after the first presentation by Dr. Bach, because Dr. Bach has to leave early. He is from the New Jersey Medical School and talking about respiratory issues, of course, a very important aspect. The floor is yours.
Well, first of all, I think you're a remarkable group. The houses are wonderful for setting all this up, but I've been to many family type of organizations and meetings and symposia, but rarely are they so large. And this is such a rare condition by comparison to muscular dystrophy or spinal muscular atrophy that I think you're remarkable people to do this. At any rate, let me get started. I haven't got a lot of time. I'm just going to tell you that it's very difficult for doctors to learn anything new. It's very difficult for politicians to learn anything new. It's very difficult for anybody to learn anything new. But that's another story. I haven't got time to tell you why. But let me just give you a couple of examples of how people get stuck on ideas. How about television won't be able to hold on to any market it captures after the first 6 months. People will soon get tired of staring at a plywood box every night. 1946, the head of 20th Century Fox. Or all of these are good. I mean, airplanes are... Anyone who has a respiratory problem has a lung or airways disease problem. We are used to treating people with lung disease or airways diseases. And so everybody is looked at as though they have lung or airways disease. So you may have said that you may think that someone with Pompe's disease has... Pompe's patients have no lung disease. They have a failure of ventilation. When you have a failure of oxygenation because the lungs are diseased, one of the treatments is oxygen. When you have a failure of ventilation, the treatment is to correct the ventilation. But that's not what's generally done. So when you see a patient, or when a doctor sees a patient with muscular weakness, they often send them for pulmonary function testing, which is essentially completely irrelevant. The only thing even slightly interesting is the vital capacity in the sitting position. But the rest of it is totally useless for people with muscle weakness. And they often prescribe oxygen, bronchodilators, CPAP. All of that is useless. CPAP especially useless. BiPAP is basically a ventilator, but it's rarely used as one. Because the settings are set up, usually people are sent home with the low spans of BiPAP, which help a little bit, but are not optimal. Now, the spectrum of disease in Pompe's disease, you all know. But I just want to tell you from my perspective that when you have an infant with Pompe's disease, the child can die from respiratory or cardiac complications. And although we can generally eliminate respiratory deaths, even in infants with Pompe's disease, usually they will die eventually from a cardiac involvement from the cardiomyopathy. Adults, fortunately, the heart is spared. Probably 100% or close to it. Maybe some of you know, maybe I'm wrong, maybe it's 99%, but for the most part, the adult onset Pompe's patients doesn't have to worry so much anymore about heart disease than we do. So it's just a question of preventing respiratory complications, and that's mainly what I'm going to tell you about. Now, this is a small child with Pompe's, and you can see they're very floppy. But the respiratory muscles that we have to consider are basically three: the inspiratory muscles, the expiratory muscles, and the throat muscles, what we call the, I meant to put bulbar. Okay, throat or bulbar muscles, okay? Now, what are they? The inspiratory muscles, throat, well, it sounds like a frog. Throat, okay. The inspiratory muscles are the diaphragm and the intercostal muscles and some other accessory muscles. Now, usually people do not go into respiratory failure because their inspiratory muscles are not adequate. That only happens when the doctor gives them oxygen, turns off their drive, and their CO2s go through the roof. Usually what happens is that when the inspiratory muscles are weak, the expiratory muscles are also weak, and all three muscle groups are weak, maybe, and that causes a decreased ability to cough. So you may be doing fine, and then you get a chest cold or a flu or something like that, and then if you're not strong enough to clear the airways, the bacteria multiply, and you get pneumonia. And then when you get pneumonia, you get short of breath, you go to the emergency room, the physicians immediately give you oxygen, that turns off your drive, your CO2 goes from 70 to 120, and you stop breathing, and then they stick a tube down your throat, the translaryngeal intubation. And then when they think that you can't wean from the ventilator, they tell you you need a trach tube. Nobody with Pompe's disease ever needs a trach tube. And that probably is true even for the severe infantile Pompe's. I can't tell you that with absolute certainty, but I can give you some examples. But certainly, the adult Pompe patient should never be told that they will ever need a trach tube because they retain bulbar muscle function, throat muscle function. You're able to protect your airways, and you see, the inspiratory and expiratory muscles can be absolutely zero. I right now have patients with zero vital capacity. The vital capacity is the deepest breath you can take and blow into a meter, and we measure that volume. Now, imagine having 0 milliliters of vital capacity. Now, normally you have about 5,000 milliliters of vital capacity, okay? Imagine 0. That means you can't breathe. You can't move any air at all. I have patients like that now for up to 57 years. People who had polio. I have many over 50 years, 0 vital capacity, none of them have tubes in their necks. Nobody has a trach tube. So we can compensate for the inspiratory and expiratory muscles non-invasively by applying pressures to the body or the airway, and simply by giving pressures. So if you give positive pressure through the nose and mouth when you inhale, that helps you breathe. If you have 0 vital capacity, then you can get your entire breath by a pressure of 20 centimeters of water, okay? If you apply negative pressure to the airway when you exhale, you're increasing your expiratory flows, you're increasing your cough flows. And we can normalize cough flows and inspiratory volumes easily, non-invasively. The one thing we cannot do is really substitute for the glottis, the bulbar muscles. If they get to the point where they are so weak that you cannot close your glottis and you can no longer speak or swallow food, and then, on top of that, you aspirate so much saliva that your baseline saturation stays below 95%. For ALS patients, 90% will be dead or trached within 2 months. That does not happen in Pompe disease because the bulbar muscles stay strong, at least in the adult variety, and in many of the young kids too. So that's the good news. Nobody with Pompe should. We now have many, many, many patients with all sorts of diseases who got so weak that they lost all ability to breathe, and in the case of Duchenne muscular dystrophy, have been ventilator dependent for 25 to 30 years and have never been hospitalized. 24-hour vent dependent, using a mouthpiece during, I'll show you, and have never gone into respiratory failure or been hospitalized. Why do people with Pompe disease, why are they left to get weaker until they get short of breath and then, get intubated and be told that they'll need a trach tube someday? This is a patient, Pompe's, but look at the nose piece. These kids are ventilated through nasal ventilation. Now, I'm not talking about BiPAP. CPAP is totally useless. It doesn't help you breathe at all. CPAP is a pneumatic splint, which the air comes through to keep your airway open so that you can use your respiratory muscles to breathe, your inspiratory muscles. It does you no good if you don't have any inspiratory muscles. Okay, it just is a pneumatic splint to keep the airway open, that's all. It's good for old guys who snore and need that air so that they can use their diaphragms to breathe at night, okay? BiPAP is where you vary the inspiratory pressure. When you're inhaling, the pressure may be 10 centimeters of water, but when you're exhaling, the EPAP, the expiratory pressure, is usually set at about 4 or 5 centimeters of water. Well, not only is the 4 or 5 centimeters of water completely useless and uncomfortable, it subtracts from the inspiratory pressure in terms of giving you a deeper breath, resting your muscles and helping you breathe. There is no reason for EPAP when you have muscle weakness, when you have diaphragm weakness. EPAP is useful for, again, patients with obstructive sleep apnea syndrome and not for people with weak muscles. So, of these things here, there's a couple of them that are, BiPAP is a ventilator. It's not recognized as such, and it's rarely used as such. We don't use BiPAP except when the glottic function is very bad. So if the glottis is good, and you can talk and swallow, and you can get a volume of air and hold it, and then another volume on top of that and hold that with your glottis, then even if your vital capacity is 0, you can inflate your lungs to 3 or 4 liters. That keeps your lungs healthy. You cannot do that with BiPAP, because BiPAP is pressure cycled. So instead of, when I use volume cycling, I'm setting a volume of a liter, let's say, and that volume ventilator delivers that liter of air. And you can take the whole liter, you can take half a liter, you can take as much as you want. You can take that liter and hold it with your throat, not let it out. Don't exhale. And then the ventilator gives another liter. Now you've got 2 liters. And you can hold it and get 3 liters. You see what I'm saying? You cannot do that with BiPAP, which is why we don't use it, except when the glottic muscles are completely gone, okay? Because BiPAP is pressure limited. You set the pressure of 20 centimeters of water. It delivers air until it feels that pressure. And then if you hold that air and you wait for it to give you another 20 centimeters of water, as soon as you open your glottis, it senses the 20 centimeters you've already got there and it shuts off, okay? That is the difference between pressure cycling and volume cycling. And there are advantages and disadvantages to each, but in general, if the glottis works, volume cycling is better for people who can cooperate to air stack high volumes. Now, polysomnography I consider essentially worthless. You have to understand that polysomnograms are programmed to interpret every apnea and hypopnea as being central or obstructive in nature, which is like blaming the brain and the throat for what the diaphragm cannot do. When a polysomnogram sees paradoxical breathing, when the belly's going out and the chest is going in, it interprets that as an obstructive apnea. But that can also be because the chest muscles are paralyzed, as we see in so many small children with neuromuscular disease. The treatment, is non-invasive ventilation. But what I'm telling you is that you go to get a polysomnogram, you lie there all night, you try to sleep with electrodes all over you, and you've got some technician watching you, and that's supposed to be a benefit for somebody with weak muscles. It was never designed for this. It was designed in the 1970s for obstructive and central apneas. It does not recognize an apnea because of muscle weakness. It's essentially useless. In fact, what is helpful sometimes is oxygen saturation monitoring and carbon dioxide monitoring. And carbon dioxide can be monitored by end-tidal carbon dioxide, where you have a pickup at the nose, or by transcutaneous carbon dioxide monitoring. And these are more accurate. Well, that's another thing. Next time a doctor wants to do an arterial blood gas on somebody with Pompe disease, tell them to get a capnograph or an end-tidal CO2 monitor, because they're not only painless and more accurate because you're not hyperventilating from the pain as you do with, well, a capnograph, just call it end-tidal monitor, CO2 monitor, END-TIDAL. It's also known as a capnograph. But the reason I consider them more accurate is because you get a longitudinal CO2 measurements, not one-point pick. And in the journal Chest some years ago, 30% of people who get stuck for an arterial gas hyperventilate because of the pain. That artificially reduces the CO2. So anyway, I've taken care of over 2,000 people on non-invasive ventilation. I've never had to send one of them for a polysomnogram. I only send older, people who I think have obstructive sleep apnea syndrome. If the vital capacity is normal, and the respiratory muscles are normal, and the patient has the same symptoms as people with hypoventilation have, because the symptoms are basically the same, I send them for a polysomnogram. But if the vital capacity lying down is 30% less than it is sitting, and the patients can't breathe lying on their backs, I'm not going to send them for a polysomnogram. That's a total waste of time. I'm going to put them on non-invasive ventilation and not BiPAP. These children have been 24-hour vent dependent since they were 4 months old. Today they're 16 and 14 years old. We now have kids, by the way, their vital capacities are 0 milliliters for 5 or 6 years for both of them. They don't use this anymore, by the way. This is the Adams circuit. They use something like a nasal air now. It doesn't come up between their eyes. This is what I was talking about. This is a capnograph. This monitors carbon dioxide at the nose. The pickup is at the nostrils. And of course an oximeter. This is a very old oximeter. Nowadays you can get them on oximeters for less than $25. And this is a $15 peak flow meter that every asthmatic in the United States has, but we use it to measure cough flows. And when the cough is less than 300 liters a minute, so in other words, there's 2 types of coughs. There's the cough that you do spontaneously, and there's also what I call an assisted cough. An assisted cough is when you air stack. If your vital capacity is under 1.5 liters, you need a deeper breath, because the average cough volume is 4 times to 5 times the average tidal volume. If I ask a doctor, what is a normal tidal volume? Everybody knows it's 500 milliliters or 600 milliliters. But if I ask, what's a normal cough volume? Nobody knows. it's 2.3 liters. So if your vital capacity is not more than that, your cough is going to be diminished even if your expiratory muscles are normal. Okay, you got to get a deep breath to cough. Basically you need all three muscle groups to cough. You need your inspiratory muscles for a deep breath, your expiratory muscles, your abdominal muscles to generate thoracoabdominal pressure, excuse me, and you need your throat muscles to hold it. Oh, come think of it, I didn't do that. I did not do that intentionally. How about that? You know, it's true, when I talk about cough flows, there's always somebody who coughs. This is the first time it was me. There's always somebody who coughs, and I didn't hear anybody cough. So I did it this time. That's amazing, wow. Any rate, and you need your throat muscles to hold that pressure, so that when you open, you get an explosive decompression, you get 10 liters a second of flow, etc. So, if the vital capacity is low and the cough is low, we do the assisted cough. We air stack the patient, give him volumes of air that he holds to a real deep volume of air. We press on the belly, we say 1, 2, 3, cough, and he coughs through the peak flow meter. And that's how we get the assisted cough flow. Now, when that assisted cough flow is over 300 liters a minute, or 5 liters a second, the cough is pretty good. And patients are going to get through most chest infections without getting pneumonia. When it's under 300, it's a problem. And the lower it is, the greater the risk. When it's under about 160 liters a minute, you're not going to recover from anything. Even a minor chest infection is going to cause pneumonia, every time, because the flows are not adequate to clear the airways. So that's when we give people rapid access to a cough assist to help them cough. This is a cough assist. In fact, I saw one out there. You can see how this works. Basically, it gives you a real deep breath. The usual pressures used are 40 centimeters of water. And then you go to minus 40 centimeters of water. And during the negative pressure, you press on the belly. Now, that is something that everybody forgets, but it's extremely important. You press on the belly during the negative pressure. I don't care whether you're using this through an oral nasal interface, or if you're intubated, we use it through the translaryngeal tube. And if patients have trach tubes, because they didn't go to the right physicians, we use it through the trach tube. Okay? But you got to press on the belly during the negative pressure. Okay? By the way, if anybody wants their trach tubes out, you come. You know, we've taken the trach tubes out of hundreds of people who couldn't breathe at all, including ALS patients. But only if they're non-bulbar, not if they have severe bulbar muscle weakness. We can't take them out then. Now, this is a spirometer. A spirometer we use not only for measuring the vital capacity, but for many other things. First of all, as you know, in Pompe disease, the vital capacity sitting can be much greater than lying down. A normal difference is only 7%. If the difference is more than 20 or 30%, often patients cannot lie down and breathe on their backs, no matter how good their vital capacity in the sitting position is. So even if a vital capacity when you're sitting is 2.5 liters, if when you lie down it's 1.5 liters, you're not going to be able to breathe lying on your back. But the other thing is we use this for air stacking too. So if the vital capacity is 300 milliliters and we pump the patient up, I have him air stacked, then he blows that through the spirometer, that may be 2 liters, you see? And every time he comes in, we monitor this. We see, even if the vital capacity is going down, the air stacking ability should go up, unless the bulbar muscles are weakening very quickly, like you see in ALS. In Pompe disease, it goes up, as long as you practice. Because if you practice, you improve the compliance of your lungs, the elasticity of your lungs. And that makes it easier for a weak diaphragm to move more air. It's range of motion. It's mobilization of your lungs and your chest wall. It's just like if you have a weak knee and you never extend it, you get a contracture. The same thing happens to the lungs and the chest wall. That's why whatever your predicted inspiratory capacity is, you need to approach that by air stacking or by using the cough assist at high pressures to give you deep breaths. So we measure the air stacking with the spirometer, which is why it's not a digital spirometer. When you have digital spirometers, it's hard to do that because every time you stop the flow of air, it has to reset. These digital things are horrible, you know? I can't stand digital things. I'm still looking for a good non-digital computer. If any of you have one, you know, let me know, okay? Because I'm really in the market for one. Now, the sad story is that at the age of 19, our vital capacities hit a peak, a plateau, and then we lose 1% or more per year. And when the vital capacity goes below 40%, the cough flows become ineffective. Okay? That's, well, as you see, below 40%, the cough flows are well below 250 liters a minute, and that's not very effective. So our goals are really three: to optimize range of motion, lung compliance, to optimize cough flows and maintain ventilation. So we do this with an AMBU bag, air stack the patient blows it through the spirometer, and we get the insufflation capacity. Now, I haven't got much time to show you frog breathing, but I know many of you must have figured I was wearing this tie to be fashionable, but this is actually an instructional tie. Imitate me once, okay? Exhale out passively. Don't use your diaphragms. Don't use any muscles below your neck. Just relax. And then take 20 gulps with me, like that, and then exhale passively again. And the air that you exhale, you will have gotten by frog breathing, okay? You ready? Okay, you see all the air you got. Now you have nothing to worry about. You can get hit by a truck, become a C1 quad, and as long as you're conscious, you'll be able to ventilate yourself all day. Isn't that comforting? And if you're not conscious, you won't know about it anyway, you know? But if you don't learn what I just showed you, and that happens, you're going to be very embarrassed. You're going to say, I should have listened to that guy. Of course, you won't be embarrassed very long, but... Now, this is somebody with a vital capacity of 900 milliliters. She's able to air stack up to 3 liters by frog breathing, just by frog breathing. And that gives her a great breath. This is somebody with 0 vital capacity, is able to maintain normal ventilation by frog breathing. A small child, look at the chest of this child with paradoxical breathing who is about to die. And look at the chest of these 2 kids. They look better. And like I said, these kids are 16 and 14 now, and this kid was probably dead a few months after this photo was taken. He's from a book by a famous neurologist by the name of Dubowitz. The guy who does great neurology but lets all of his patients die. This is optimized cough flows is the next goal. And that's because you need inspiratory, expiratory, and your bulbar muscles to cough. So if the vital capacity is under 1.5 liters, you inflate the lungs, press on the belly, and we measure those flows. You can use your head if your arms are weak. And you cough through there. And if the lips are too weak, you cough through a mask like that. Okay? This is an assisted cough. You press on the belly, 1, 2, 3, cough, after the air stacking, and that's how it goes. Okay? And look at what happens when you do that. Ineffective cough flows become effective. And this is probably the best image of why we never even have to think about trach tubes, except for the bulbar ALS patient. And this is a 72-year-old who, you could see, he fell out of an apple tree in his backyard and broke his neck. 200 milliliters of vital capacity. We took out his trach tube, but then we discovered he couldn't swallow anything without aspirating. So we let him, after every 3 swallows, he uses his cough assist to bring up what he aspirates. And that works fine. 72 years old, you know. This is a cough assist, an old one. And again, it gives you a deep, deep breath. The pressure drops to about -40 centimeters of water, and that's 10 liters a second of flow. In the meantime, you press on the chest, or even better, press on the belly to increase those flows. And finally, to maintain ventilation, it's because a weak diaphragm is like this poor horse here. If you don't give him some rest, he's going to collapse. The ventilator is like a pickup truck, but not if you use it at BiPAP settings. To rest your muscles, you've got to use it at settings that you would need to ventilate your lungs. And normally compliant lungs, you're not going to ventilate me if I'm a C1 quad with a pressure, with a BiPAP of 10 and 6. I'll be dead in no time. You got to give me a pressure of 18 to 20 centimeters of water. So how can you rest muscles unless you do it at proper pressures? And that's why, you know, BiPAP is not helpful, not helpful enough. There's a nose piece. Just to point out that nasal ventilation is the most popular method of nighttime ventilatory support now. But it's not the only one. Oh, this is a patient whose trach tube we removed. He's 24-hour vent dependent for about 20 years now. And for kids, there are different interfaces. Actually, the Respironics has a mini interface for 6-month to 4-year-olds. And it's very, very good. Everybody's got a different kind of nose. So don't expect one interface to satisfy everybody. Also, there's over 100 on the market now, so you can get a comfortable nose piece. Now, if you leak too much air during sleep, you'll wake up short of breath. and your CO2 will go up, and your saturations will go down, right? And they can go down very severely. When this happens, don't stuff the mouth. Don't stuff the mouth or cover it. Doesn't work. Ventilate through the mouth. Lip seal, right? But even better than all this now, what we're using more than anything to normalize the gases is a Liberty or a hybrid interface. It's nasal prongs, so there's no pressure on the nasal bridge, and it delivers air through the nose and mouth like that. We even use it on surgery for these patients. And mouthpiece ventilation. Simple and extremely important. All you got to do is put a mouthpiece by the patient's mouth and they can ventilate themselves all day. We only use the nasal air here, like you, sir, when the lips are too weak to grab a mouthpiece, basically. But, you know, it's mouthpiece ventilation with the gooseneck clamp set up next to the mouth is very effective. Okay, so I'm just about out of time. This is a sip and puff wheelchair with the mouthpiece next to it. Chin control wheelchair with the mouthpiece. Gooseneck clamp with the mouthpiece. A microphone holder with the mouthpiece. This young man did this for 25 years. In fact, I showed you some others that even more than that. But I think about that because he just died 1 month shy of his 48th birthday. And he has actually has muscular dystrophy. And he had a cardiomyopathy for 20 or 30 years that was documented, you know. And he had breakfast the Saturday morning, and he was talking to his brother, and boom, he just died like that. No apparent pain, but I went to his cardiologist, and I said, well, maybe he should have had a defibrillator, you know, or a pacemaker or something. But I was thinking he would be my first 50-year-old Duchenne patient. I have about 3 or 4 others now over 45. And his lips were too weak to grab a mouthpiece, so he uses the nasal air. Okay. Okay, I already said that we don't use Bipap except when the throat muscles are completely shot. So we'll use an LTV or a Trilogy. Now the Trilogy is a new ventilator that can be used like Bipap with a passive circuit, but it can also be used like a volume ventilator or pressure control ventilator with what we call an active circuit. The most common mistake, see, everybody's familiar with Bipap and CPAP, and the doctors prescribe this after doing polysomnograms. And then you have a CPAP mask, okay, attached to Bipap. And then if they come to see me and I say, no, I want you using an LTV or a Trilogy on volume cycling. So then they go back and the home care companies use the same, they may change the circuit to an active circuit with an exhalation valve, but they don't plug the holes on the CPAP mask. So all the air leaks and the patient doesn't understand why he's not getting any air. There are many little technical problems that people just don't understand because they don't have the concept of non-invasive ventilation. So for most people, non-invasive ventilation is just nighttime CPAP and BiPAP. But again, that's not the way it should be for people with muscle weakness who need inspiratory pressure, not expiratory pressure. There's no reason to have EPAP when that subtracts from the IPAP that you need to help you, and when it's uncomfortable, like breathing with your head out of the window of your car. Okay? So, and this is an old PLV, that's very nice. We have an outpatient protocol where we give a patient oximeter. Whenever the saturation goes less than 95%, when they're sick, it's either 1, ventilation, they need to use their ventilator. If that doesn't bring it back to 95, 2, they got airway secretions. If they don't get the airway secretions out, they get pneumonia. It's as simple as that. You keep your SATs normal and stay far away from doctors and especially x-rays because they lag days behind the clinical picture. Get an antibiotic, but I tell people to stay away from physicians unless they can't get their baseline saturation back to 95. Then they almost always have pneumonia and they need to be in the hospital. Nothing wrong with being intubated. When you get intubated, you get healthier quicker. But you have to have people who know how to extubate even if you can't breathe, you see. I'm not going to talk about extubation because I don't have time, but we consistently are able to extubate unweanable people without even thinking about tracheing them. So, and we take out the trach tubes of many, many, many patients who never should have gotten them in the first place by putting the patient on non-invasive ventilation, and when they're used to it and not using their trach anymore, we take the trach tube out. And actually, this is nice. This is a patient on trach ventilation. I think she had Pompe's, in fact. We show her mouthpiece ventilation. She's on mouthpiece ventilation. We take out the tube. The therapist puts on There, okay, there it's out. He puts on tegaderm, or ideally duoderm, over the ostomy. Then, that's it, there we go, there's tegaderm. Then we find a little old lady with a cane. We steal the cane, cut down the walls of the cane tip, and give her back her cane. And then we put the cane tip over the ostomy, and then some tape on it. And then a figure of 8, you know, like an ace bandage. And there you go. And then 3 days later, the site is closed, and the patient never gets a trach again. Okay, yes, you have a question?
Yes, Dr. Mark, I was going to ask you, if you could go a couple pictures back to some of the headgear, the one, and I'm only asking you a question because you got your slides up there now.
Okay, headgear, yeah.
Some of the headgear ones, we go back a little bit further. That's not bad. The nasal ventilation's not bad either. Anytime, what I'm trying to do is, is that I'm just trying to find the difference between invasive and non-invasive. When you say that a trach is somehow invasive, I look at these people, like that particular gentleman there, anytime you're being pressure ventilated via the nose or the mouth, it seems to be almost more invasive than even a trach tube, because you have headgear on and you're cramming all this air down somebody's nose. And like in my case with my son, when we had the headgear on with his Bipap and everything else, I could not see him. I couldn't kiss him. I couldn't talk to him. I couldn't fondle him. I couldn't snuggle with him and everything else. And he had this contraption over his head. As soon as I got the trach, it was like this liberty. And I understand the fear of tracheostomies, but we have never had a problem with the tracheostomy. And I guess I'm trying to sort of give a little shout out to the people that have tracheostomies that have, unfortunately, we really don't have any other choice. But yet, we've made it work, and it's been quite nice, and it's probably been the best thing we've done. So I try to compare, because I see these presentations all the time, and I try to compare what's really invasive and what's really not. And it's,
that's a very good point. And let me tell you, every disease is different, and every patient is different. So, for example, you're using a different definition of invasive. I think you mean encumbering or something like that,
Right.
And I appreciate that. If you look at patients with Duchenne muscular dystrophy, there's a study out of Japan where up until 1983, nobody was treated, so the average age of death was about 18. From 83 to 93, everybody got trached, and the average age of death was about 30. From 93 to now, the life expectancy is 40. What's the difference? Because people can die from complications of the tube. Bleeding, infection, mucus plugging, pneumonias, fistulas between the esophagus and the trachea, tracheal stenosis, tracheectasis, where the trachea literally blows open. You see?
I guess I should knock on wood because we haven't had any of those problems. Because we really
no, but how long has he had a trach?
9 years.
Okay, so that's already better than the average. That's already better than the average, and you are lucky. And there's no cuff on that trach, right?
Correct.
Okay, the cuff causes tremendous problems. Right. Okay. Now tell me, can your son speak?
No, that's disease related because he's got infantile Pompe disease.
Okay.
It's severely affected.
And that's what I'm getting at. I take care of a lot of patients with SMA type 1. And with SMA type 1, the kids often by 2 or 3 months of age, they can never speak or swallow food, and the parents have a hard time with airway secretions with them. When they get the trach, the parents feel better. They were resisting it, but they actually feel better. See, it really depends on the situation. I'm not saying that a trach is only necessary when you aspirate so much saliva that your saturations go down. That doesn't happen in SMA, even type 1, and it probably doesn't happen in Pompe disease. But that doesn't mean that a trach cannot be beneficial in many ways. Excuse me. It's more convenient. And no, I thank you for your comment. And I agree with you 100%. But if you told me that your child could speak and swallow food, I would say that was the worst thing that you could do.
Right.
Okay.
Thank you.
Sure.
More questions?
Yeah.
Yes, please. The mic is...
So let's just say hypothetically we had Pompe disease and you lived in the hinterlands of Montana where nobody knows what it is. How do you school up a respiratory doctor into getting the right settings on your Bipap?
You see, well, basically, like I've said, the doctors are almost uneducable, just like politicians and every other specialty. We learn what we learn as students and residents, and then we learn we forget more after that than we ever learn. So you can't expect to educate anybody because people get mindsets. That's called paradigm paralysis, and very rare. Now, lay people will learn this stuff because it may be new to them, and it's common sense. I shouldn't say common sense, but it's simple to understand, putting it in plain terms. But when you have a specialist who has always treated one thing one way and looks at another thing the same way he treats everything else, you may never be able to convince a local doctor to even look at the problem properly, okay? But it doesn't matter. You know, I get patients to come to me from all over the country, and right now I have a patient from Qatar, which is why I'm flying there tomorrow. But when you have these patients, so now Qatar, nobody knows anything about this in Qatar, but the woman is using non-invasive ventilation anyway, and I'm going to go and try to educate some doctors over there.
How would us as an adult onset patient learn that for ourselves to teach our doctors or respiratory therapists?
No, but learn what exactly?
On how to set a BiPAP
Okay.
or ventilation we should be on.
Get a copy of one of my books, copy out the chapters, and stick it to them. You know, tell them to look up my name on. You know, look, I have 210 articles in pulmonary journals.
Could you send the copy to?
Yeah, you send me an email, and I will send you copies of articles.
What's your email address?
bachjr@umdnj.edu. In fact, I think it's.
And they can supply.
And the information goes directly to his website, so check it out. And I agree 100% with what you're saying. Our first pediatric pulmonologist treated Tiffany as if she had cystic fibrosis.
Yeah, exactly. That's what happens. Right.
It's not working for us,
yeah.
and we knew it.
Now, this is the
And
website.
One of the ways that we learned how to work with the pressures we did it.
Right. No, you have to. See, we teach, when people come to our clinic, our respiratory therapists teach them everything they need to know. And then, if they can't find a home care company to do it in their state, his company, the company he works for, will find a therapist there, have him trained, and that therapist will build up their practice and make a lot of money because they have no competition. Do you understand?
Yes, and we were told to have her trained several times, and we resisted.
She will never need a trade. Never. Never.
Well, that's just personal experience.
Oh.
You really do have to take up for your child or yourself.
Yes. Yes, you do. This is my last book, and it's not just respiratory, it's everything else too. And that's
More
the
questions?
website. Yeah. Any other questions? See, about BiPAP and volume cycling, if you use BiPAP at high settings, like 20 and 4, that's the equivalent of 16 and 0, which is pretty good. The problem is when doctors want to give you 12 and 8, you know? Then you only get a pressure support of like 4 centimeters, which is almost nothing. But it's still helpful, okay? But it's uncomfortable and it doesn't address the problem. And to make doctors understand that, you got to... See, they make about $5,000 from each polysomnogram. So they don't want to learn anything that would discourage them from prescribing polysomnograms. You know, it's like George Bush wanting to discourage, the oil industry. Here I am in Texas, It's not going to happen. If you make your money in something, you back it up. It's the way it is. Yeah, good old George.
Okay, if there are no more questions, then thank you very much, and I really thank you. Send the email, because there's so much more to tell, I have the impression. So send an email and ask for instructions, A, B, C, D, or 1, 2, 3, 4, and then you will have the answer. Right? Next speaker is Dr. Jones, and you use this symbol here.
Yes, sir.
And then it goes from Duke University, North Carolina, about swallowing and dysphagia, which is not swallowing so well.
Correct.
Correct.
Crystal, which can be whatever, eating and talking.
Is that my mic?
How's everybody doing? How's my volume? I kind of tend to be sort of loud. No. Nope? Okay, if I start getting excited, though, and start yelling at everybody, you can just tell me to calm down. So I thought that was a really interesting presentation by Dr. Bach, and I agree with almost all of it. Except for the fact that there is accumulating evidence that the throat muscles or the bulbar muscles are indeed affected in Pompe disease, not just in the infantile form, but also in the late onset form. So I'd like to talk a little bit about that and what that might mean and some of the data we've recently collected on that. So I'm here to talk about bulbar muscle involvement in Pompe disease, speech and swallowing disorders, and the setting of lingual weakness. So who am I? Everybody else seems to know each other here a little bit. I'm kind of new here compared to everybody else. I'm a speech-language pathologist. I'm not a physician by training. I've been a speech pathologist for about 10 or 12 years, 12 or 14 years. Got my PhD after practicing for a while. I continue to be a speech pathologist. I spent about half my time in research and about half my time with patients, maybe a little bit less than half my time with patients. I'm also a scientist, researcher. That's what I wake up in the morning excited about. Husband and father. I got two boys, a 5-year-old and a 2-year-old. My wife says, our family's not full. No drugs for me. Yeah, I'm not talking about myself. I don't talk about how I don't take drugs, although I don't take drugs. I don't study drugs really, or I'm not gonna offer you a drug as part of a study. I don't want to study exercise to make the drugs work better, or many of my patients are on medications and stuff like that, but you won't get any from me. I'm trying to keep up with technology until my kids are grown. I'm seeing how fast all this stuff's moving along, so trying to keep up. And I like to make marbles in my free time too. So what is bulbar muscle? What are we talking about when we talk about bulbar muscle? Well, I mean, is Dr. Bach still here? He had to leave right away, didn't he? We're talking about throat muscles. We're talking about the muscles which control and which are responsible for the movements of the head, face, and neck. Structures such as the tongue, lips and face, and jaw are dependent on these muscles to move. They are innervated by cortical bulbar tracts, which originate in cranial nerve, brainstem, sensory motor nuclei, primarily in the medulla, and that's where the bulb comes from. There's a few in the pons as well. But these muscles are critical for speech and swallowing. If they're not operating correctly, speech and swallowing problems, or depending on your exact definition, dysphagia and dysarthria is essentially inevitable. These muscles are critical for speech and swallowing, as well as many other activities we do with our mouths. Coughing, kissing. That's one I thought of this morning. Might not sound like a big deal, but I don't know. Until it's taken away from me, I guess. So these are really important muscles. And they do seem to have some unique properties in comparison to skeletal muscles. They don't respond to medications the same way. They have widely varying fiber compositions in comparison to the skeletal muscles. Even among the bulbar muscles themselves, they're all wildly different. They tend not to work around joints, for instance. All the muscles we think of are joint muscles. They're very, very different muscles. Even the jaw, which seems to be kind of a jointed muscle, isn't really. So they're a lot different, and they respond differently to a variety of treatments. We're not entirely sure why that's the case, but we're learning more and more. In Pompe disease, by the way, when am I off stage? Anybody know? I kind of lost track of. I started at 2:10. When am I done? I want to plan.
You don't need an apparatus.
Okay, I'm going to try to go 20 minutes, so I start at 2:10, done 2:30. All right.
I'll let you know, but it's short, because we are short in time.
Well, how short then? Shorter than 20?
Anything you can spare, we are grateful.
All right. Should I sit? Okay. So Pompe disease, we typically associate that with skeletal muscle disease. Those include the respiratory muscles and cardiac muscles, especially, of course, to the infantile population. However, there are accumulating data that these bulbar muscles are affected as well. In children, this is in the pediatric infantile form, this is not particularly difficult to see. I know Dr. Krishnani earlier played some speech samples that were very highly suggestive of bulbar dysfunction with hypernasality in a child's speech. There is anecdotal evidence as well as a preliminary report or two about dysphagia in this population. And again, this appears to be due to bulbar muscle dysfunction, bulbar muscle weakness. However, we've always thought that in late onset disease that did not occur. So in terms of the accumulating evidence, there's a recent MRI, a muscle MRI, and they found all facial muscles were spared except for the tongue, in which fatty infiltration was intense and precocious. Some muscles in other regions, such as tongue muscles, were consistently and predominantly affected in all groups, and their involvement may be very suggestive of Pompe disease. I think that's important. So this is really the work I'm here to talk about primarily today. This is an article that's, I think, in press in Muscle and Nerve Journal, talking about expanding the phenotype of late-onset Pompe disease and our findings of lingual weakness in this population. So as a little bit of background for the study, one of our colleagues, as part of his routine neurological exam in individuals with Pompe disease, assessed 2 patients consecutively and performed manual muscle strength testing of their tongue. To do this, people push with their tongue against the left and right inside of their cheeks, while the examiner provides resistance with their thumb. The patient should win unless they have weakness. We're not able to overcome the tongue unless there's abnormal strength there. The tongue is very, very strong. So this happened in 2 consecutive patients, and this led to further investigation. So an additional 17 consecutive patients, so 19 consecutive patients with late onset Pompe disease were studied, so for a total N of 19. And this was between September 2007 and August 2010 down in Argentina. Again, the lingual muscle strength testing, we're pushing actually against the thumb, against the thumb, and sometimes you put a little pressure here on the head to keep things straight and even. The examiner was unblinded as to the participants' status, whether they had Pompe disease or not, but he did have over 30 years experience in the use of MMT, or manual muscle testing. And this is our these are the definitions we use to rate the severity of lingual weakness. Of course, it's either normal or abnormal. If it's normal, you got normal strength. If it was abnormal and weakness was detected, we used these operational definitions and their associated functional symptoms to categorize the severity. So someone with severe lingual weakness, the patient is unable to push with the tongue against the inside of the cheek to provide any resistance to the examiner. And that person would have functional symptoms such as overt dysphagia or swallowing problems and or dysarthria. And we studied a total of 13 males and 6 females. Interestingly enough, 2 of the patients were asymptomatic and were only diagnosed due to a positive family history. History of symptoms ranged from 1.5 years to 32 years. Patients were 14 to 78 years old. 12 of 19 were on ERT. Those who weren't for a variety of reasons. We found very surprisingly that tongue weakness was present in 100% of the 19 patients. All the patients exhibited tongue weakness, every single one. That includes the 2 patients that were asymptomatic. So most of the patients were mild, had mild tongue weakness, about 63%, or 12 of them, I think. But it was 7 of them had a moderate to severe lingual weakness. So although the lingual weakness was generally mild, especially in comparison to the other symptoms, it was, again, present in everyone who was studied. And in contrast to, this is a frequently asked question, in contrast to the infantile population, we saw no evidence of macroglossia in any patient. And it appears that tongue weakness occurs frequently and early in late onset Pompe disease. So, what does this mean? Well, I think one, the presence of lingual weakness, may be suggestive of late onset Pompe disease. Now, I said that to somebody else, and they sort of argued with me. I'm not saying that this would be a presenting symptom. I don't think people are going to go to their doctors and say, my tongue is very weak, and I've been noticing that, when I'm pushing really hard against the top of my mouth, I just don't have the oomph I used to. No, they're going to go with more typical classic complaints. But on examination, if the patient exhibits lingual weakness, it may raise the suspicion of Pompe disease. Perhaps. And considering all the challenges of differential diagnosis that I'm sure many people in this room know better than myself, I think this could be important. Especially important now that ERT is available and we want to start people on therapy as soon as possible. So we don't want to waste too much time. And this is consistent with that earlier report that I described, where the MRI revealed pervasive tongue involvement in their participants. And again, we saw pervasive tongue involvement based on strength testing. Okay. All right, so does it even matter? Sure does. Functional deficits may occur, dysarthria and dysphagia, difficulty speaking, difficulty swallowing safely. 1/3 of our subjects had oral stage dysphagia upon questioning, such as impaired bolus control, oral residue. Severe dysarthria was present in 2 subjects, and one of those 2 had tongue atrophy as well. What about the children? This is where I cue in the Whitney Houston song, The Children Are Our Future. Had to take that out, though, because all the technical problems. Definitely have evidence of bulbar muscle involvement, too, and in fact, much more prominent, much more severe, much more noticeable. They also have dysarthria. I would describe it as a flaccid dysarthria involving which the neuromotor component is that which causes speech disturbance, being that primarily of weakness due to muscle disease. So it's time for me to wrap up, I understand. Implications of future directions. The bulbar muscles do seem to be affected by Pompe disease. It's really not that surprising. We haven't found that many places where if we look hard enough, Pompe disease won't go. I think that this may be more meaningful now with enzyme replacement therapy and extended lifespans. I think that we may see dysarthria and dysphagia in late onset disease more often as people live longer. We have encountered it rarely, but somewhat in our clinic. I think that these problems will require behavioral treatments as well as drug treatments. They must be developed and refined to target these underlying neuromotor deficits. We've talked about muscle fiber here today. Well, exercise, strength building is thought to shift muscle fiber type to a greater preponderance of type 1 muscle, which may be another advantage. In terms of the behavioral treatments, I am working on this now. I don't necessarily have them to provide now. We need instrumental data regarding tongue strength, and we've been collecting those with a transducer. And we're finding very similar results. And relationships between tongue strength and other variables need to be determined. The effect of enzyme replacement therapy on bulbar musculature is very unclear. It seems to be not quite as effective as it is in other parts of the body. Same thing happens in Parkinson's disease with levodopa. It's very effective in the skeletal muscles, less so in the bulbar system. And how often do dysphagia and dysarthria occur from these things? We've also considered the idea that enzyme replacement therapy and exercise may be synergistic. So I had some really fascinating pilot data here that I don't have time to share. So I'll just real quick, fascinating, but I want to make some acknowledgments and disclosures. I'm happy to talk about these data later, showing this woman who was profoundly weak
growing stronger with exercise of her respiratory musculature. But anyway, I want to thank the House family for inviting me and for all their work over these years. Tiffany House in particular for inviting me, the AMDA. Thanks to all my patients and their families, my co-investigators on this project and other projects. And I do want to acknowledge grant support from the Enzyme Corporation and the Anna's Angels Fund for Down Syndrome Research. And that's a wrap.
Thank you so much, and thank you too for being right in time. We'll take the questions afterwards, because we have 2 more speakers in this session.
If anybody wants any marbles, just let me know. I brought some.
Okay.
I can't seem to close.
Next speaker, Linda VanderBerg, a fellow at Erasmus MC, and she will talk about muscle training.
My name is Linda VanderBerg. I'm a PhD student and movement scientist at the Erasmus Medical Center in Rotterdam and the Center for Lysosomal and Metabolic Diseases. And yes, I do study exercise. I want to thank Tiffany and Family House for inviting me to have this talk here, even before this study was ever started. So thank you. And today I will talk about our Erasmus MC exercise training study and tell you something more about the background, the aims of our study, the study design, the results, and at last the conclusion. So the background. We know that exercise training in healthy persons has beneficial effects on skeletal muscle fibers. So it increases the muscle fiber size, so you get bigger muscle fibers. And it can change the distribution of muscle fibers. As you was told this morning, you have different flavors of muscle fibers. One is more applicable for endurance exercise, and the other is more applicable for strength exercise. And by training these different kind of muscle fibers, you can change the distribution of them. And even you can possibly increase the actual amount of your muscle fibers. And by all these mechanisms, you can increase your muscle strength and improve your muscle function in healthy persons. But beside those effects on the skeletal muscle fibers, exercise training has also benefits on your heart, lungs, your bone density, and of course your physical well-being. So the background of our study, as we heard this morning, enzyme replacement therapy stabilizes or improves muscle function and pulmonary function on a group level. And what do we know about exercise training in Pompe disease? There are some earlier studies on exercise training, and one is the study of Dr. Slonim, and he showed a significant improvement of muscle function and pulmonary function after 6 years of submaximal aerobic exercise training. This was in a small group of patients and in combination with a protein-rich diet, so you can't really tell the benefits of the exercise training itself. Furthermore, we have a study of the German group who studied the effects of enzyme replacement therapy, and they kind of proved that a subgroup of patients who exercised during the enzyme replacement therapy did better on the enzyme replacement therapy, but they didn't look at the effects of the exercise training itself. And the last study is of the Greek group and is recently published. They showed a significant improvement of muscular strength and functional capacity in late onset patients who are receiving enzyme replacement therapy. This was done in a group of 5 patients, so it's a small group, and they only looked at some parameters of training. So they looked at the functional improvement, the muscle strength, and the body composition. All those studies want us to improve the effects on enzyme replacement therapy, and not only on endurance, but also on muscular strength and muscle function, body composition, and also well-being. But I think one of the most important parts of the study is to produce an evidence-based advice for all the patients about the benefits and safety of exercise training, and how do you have to implement your exercise training besides your enzyme replacement therapy. And I think the need for such an advice is very big among all patients. So what did we do? We included all patients above the age of 70 years. All patients should have receiving enzyme replacement therapy for at least 1 year, so we have an idea on the course on enzyme replacement therapy. All patients should be ambulant and free from the ventilator. We pre-selected the training center, and the training center should be near home of the patient, so the patient was able to go train 3 times a week near home. And all centers should have a physical therapist who can supervise the training every time the patient is in the center. And we ask patients to train 3 times a week for 1 to 2 hours, I think it was last. And we started with some endurance training, a block of 15 minutes, and it included walking or cycling or rowing. And after the endurance training, we did 7 strength exercises for the arms, the legs, and the trunk. After the strength exercises, we did again a block of endurance training, also 50 minutes, and you can choose walking, cycling, or rowing again. And after that, we did some core stability exercises. And you can see one over here. This is the side bridge. We also did the front and the back bridge. And these exercises are important for your core stability muscles. So we visited each center every 2 weeks, so we can see how the patient is doing and if there are any questions for the physical therapist. And we called the patients each week to see how they're doing. So we had 2 groups of patients, group 1 and group 2. And the first group trained the first 12 weeks of our study, and were asked to stop after the 12 weeks. And the second group didn't train the first 12 weeks, but the last 12 weeks of the study, so they provide the control group for the first group on enzyme replacement therapy. And we did assessments at the beginning, at the middle, so after 12 weeks, and at the end of the study. And we did a lot of assessments. So we did a laboratory investigation where we looked at muscle parameters like creatine kinase and the transaminases. We did daily activity monitoring for 3 days, so we can set your daily activity level. We measured endurance by a maximal and submaximal bicycle ergometer test and pulmonary function test. We measured muscle strength by a handheld dynamometer. We did a quantitative muscle testing and the manual muscle testing. We measured muscle function by a 6-minute walk test, by some time test, and a quantitative muscle motor function test. We assessed a muscle biopsy in those patients who would like to have a muscle biopsy. We did the core stability testing, and we did it by measuring the time and balance for each exercise for the core stability. We measured body composition and well-being by questionnaires. So I can show you some preliminary results of our study. First of all, the 2 groups of patients. In total, we had 25 patients in our study. And I think the 2 groups are equally divided. With a mean age of the patients from around 44 years, they are all about 15 years of disease duration and treated for about 3 years with enzyme replacement therapy. So we measured safety by measuring serum creatine kinase levels, and we did it every 2 weeks prior to the infusion with enzyme replacement therapy at home. And we saw that the levels of serum creatine kinase stayed within each patient's normal range, so not a normal healthy range, but your own normal range. Except 2 patients, they showed an extreme high level in the first week of training, and we think we over-asked them because it was combined by muscle soreness and fatigue. And we set the training that week, and they trained it themselves again. But after this week, it was normalized, and it stayed normalized during the whole study. So I think we can say on basis of this that exercise training in Pompe disease is safe. What were the patient's expectations? We gathered them by an interview before we started the exercise training study. and patients want to increase their endurance, their muscle strength, the quality of life, and the core stability. But they also want to improve the effects of enzyme replacement therapy and learn to cope with their disabilities. And what are the expected problems? I have to say that in most patients, they didn't expect any problems. But if they do expect any problems, it was muscle soreness or muscle damage, a lack of energy caused through the training program, problems with the core stability exercises, and problems completing the program 3 times a week. So what are the results of this study? If you look at the effects of muscle endurance, we did 7 exercises in the program, and we set each exercise at the beginning of the study on a certain level. So what we did is we asked the patients to do 4 repetitions of each exercise. So in case the chest press, we asked the patients to do 4 times a chest press exercise, and we increased the weight just till the moment the patient can barely stand those 4 repetitions. And we set the training level at 70% of this. And at the end of the study, after 12 weeks, we looked at the weight of the exercise at that moment, and we set the beginning at 100%, and we looked at the end how much percent is the exercise at that moment. So as you can see over here, all exercises, so the chest press, the seated row, and the biceps curl, are increased. So patients increased their muscle endurance. And this is in all 25 patients. And even the more affected muscles, like the leg press, the leg curl, the hip abduction, and the hip adduction, are increased. And even the hip abduction and adduction are almost increased to 100% of the beginning of the training. So there is a very good training effect on muscle endurance. And we ask patients to evaluate their training, so the training on the training days, but also give a score on the day after the training, so we get an idea about the fatigue and muscle soreness the day after the training. And what you can see on the x-axis, you can see the weeks of training, and on the y-axis you can see the score that patients give to the training. And you can see groups of 3 bars in every week, because the patient was asked to train 3 times a week. And what you can see on the left panel is the score of the training days, that the first 6 weeks or 5 weeks of training was very hard, and patients scored them as heavy or extreme heavy, and you can see a wide range of the scoring. But after the 5-6 weeks, training was scored as moderate or maybe stiff, so it gets used to training for the patients. And the days after the training, you can see the first three weeks of training. It was difficult to set the training on the right level, so patients felt more stiff and heavy the day after exercise with a wide range of scores. But after the 2 weeks, it normalized, and patients found training easy or moderate, just like healthy persons do. So I have to get you to 2 definitions of endurance before I can explain you the results of the study. You can measure endurance by 2 ways. You can look at the VO2 max, or your maximum oxygen uptake. It's just a factor which can determine your capacity to perform an exercise training. And it more or less tells you how more oxygen you can take, how more energy you can produce. So we look at that by a bicycle ergometer test. But we also looked at the anaerobic threshold, and that refers to the point during exhaustive all-out exercise at which lactate builds up in your muscle, so when your muscle becomes fatigued. So we looked at those 2 parameters in our study, and as you can see at baseline, all patients except 2 had a lower endurance level, so a lower VO2 max, compared to sedentary, healthy individuals. And the effects of training showed that 17 patients increased their endurance, 5 patients remained stable, and 4 patients slightly decreased. One of them decreased more than slightly, but he had an injury at the moment we tested them at the end of the study, which wasn't related to the exercise training study. Thus we can say the decrease is caused by the exercise training protocol. Even 2 patients normalized their endurance. So at the end of the study, 4 patients instead of 2 had a normal endurance compared to sedentary, healthy individuals. What about the anaerobic threshold? So the point at which your muscles become fatigued. At baseline, 21 out of 25 patients had an abnormal anaerobic threshold. The muscles become more easily fatigued compared to healthy individuals. And I think that's one thing you all can notice in your daily living. And what are the effects of training on this anaerobic threshold? After training, 70 out of 25 patients had a normal anaerobic threshold. So 8 persons had a normal instead of 4 patients at the beginning of the study. So the anaerobic threshold can improve due to endurance training. What about the patient's expectations before the training and after the training? In 5 patients, the expectations were more than expected, and in 6 patients it was expected. In 6 patients, the expectations were less than expected, and in 2 patients it was below expectations. What are the positive experiences of our patients? Now, all patients found that they increased endurance, they increased muscle strength, patients felt less fatigued and had to have more energy due to the exercise training program. Some patients showed some functional improvement, so they could better walk, cycle, raise from the floor or bend over. And I think one of the most important benefits is the guidance by the physical therapist, because the physical therapists were schooled and they know how to what is Pompe disease and how they have to guidance the training of the patients. Of course, there were also negative experiences. One of them was the training frequency. It was too high, and the training duration was too long. Patients had a decreased level of energy the first weeks of the training, as we can see in the evaluation of the training scores. And patients were more focused on the disease and the disabilities, and it was one thing we didn't take into account, but it's an important thing of the exercise training study. And there were patients who hoped for a more functional improvement, so it didn't bring some functional improvement in all patients. So what are preliminary conclusions of the study? It's safe to follow an exercise training protocol besides your enzyme replacement therapy. Exercise training can improve your training scores. It improved endurance and your anaerobic threshold in most patients. And a majority of patients experience a better endurance and better muscle strength, more energy and or a functional improvement. But the intensity of the program was too high. So I would like to thank our whole team and Professor Harm Kuipers from the Erasmus of the University of Maastricht, and of course all patients who participated in this study, and Wilma Treur would tell you some patients' experience about it. So thank you.
Thank you, Linda. This was the investigator's experience, and now we will hear the patient's experience by Wilma Treur. Wilma Treur is also a board member of the IPA.
Thank you very much. Thank you for the introduction. As an IPA board member, I have been often to conferences like this, and I'm every time very impressed and happily surprised by all the information we hear. And to get all the information, we need very dedicated scientists, doctors, researchers, industries who are collecting all those data, because we live in a society that's making only decisions on proof and on data collected, what is saying this is good for people or it isn't good. So I want to thank all those scientists and all the people who are working for all those years already on getting all this data and information that they want to share with us. So that's one thing that's actually very important. But one of the other things is that they can only get this information if we will help them. So this is one of the things when I heard about this sports program from Erasmus, I was very willing to volunteer for this sport program, because I think we have to do it together, we have to collaborate and to make sure that we can make the good decisions for the future and to find a good cure for our disease. Willing and doing this voluntarily at this sport program was not a punishment for me, because I really like to do fitness. And I heard my diagnosis about 7 years ago, and before that I was doing aerobics and fitness too, maybe something even 3 times a week. But when I heard my diagnosis, that changed, because one of the things I heard is that you had to be very careful with doing exercises, because you could damage your muscles. And that was for me a reason, at least, to go back in exercising. And I just maintained to doing this for once a week. I went to a physio fitness and I was just doing, well, on a very low level, some exercises. And I was wondering, how many of you are doing any physio fitness at this moment? I see a few people. And how often are you doing it? Who is doing this once a week? Oh, we've got one. Are people doing it 2 or 3 times a week? Okay, so it differs a lot. And so when I heard about this sports program, I said, yes, I want to do this. This is a great opportunity for me to do something about this disease, because it's giving me a chance to keep my own body in a good condition. I didn't know at the moment when I said I want to do this program how tough it would be. I have to admit that. And when I saw the program, I said, oh, oops, this is going to cost a lot of time and energy. But we started with the tests, and it was 2 or 3 days. We had to go to the Erasmus, and we had a biking test. They did a test with muscle strength, and they had this really cute program. It was made for children, but they tie you to the wall, and then you have this computer, and you can choose between a helicopter or a motor, and you can choose the color, and somehow it's working, because you really get enthusiastic about this thing. And you have to give a lot of power, and then the motor is going up, and you have to hold it till it's losing the screen. And that it was really fun to do, but it was tough, because after those testing days, I really had 1 or 2 days that I would call them elephant legs, you know what I mean? They were really heavy, and you really have to drag them with you. And then finally we could start with the program. That was the biggest challenge, because you also already heard from Linda that it was tough to get those 3 exercise days fit in your daily life. I couldn't go to my boss and say, well, they want me to do some sport programs 3 times a week, so I thought I'd stay home for 3 months. I had to do it within my life. And I'm a single mom. I've got a beautiful daughter who's 14 years old. I'm a basketball coach. I work 4 days, 4 hours a day. I'm volunteering in the IPA. I'm volunteering in the what we call the Dutch AMDA. So I am a busy lady. So I was thinking, wow, when am I going to do this exercising? If I do this after I worked, I will be too tired to do it. So I started at 7:30 in the morning, 3 times a week almost, to do this exercise for 2 hours. It was longer than 1.5 hours, 2 hours exercising. I rushed home, took a shower, went to my work, and I was back around 3 o'clock. And then I was sitting on my couch like this for 2 hours almost. So my daughter was coming home and said, are you okay, Mom? I said, yeah, I'm fine, but I think we'll eat something simple today. We eat did a lot of simple food the first weeks because it was really tough the first weeks. And after 4 weeks, it normalized a little bit because then you get in the rhythm and things become a little bit easier. What about the exercises itself? Most of them were not really hard to do in a way, especially not with the arms. They were okay, they were fine. But it is important that you build up things slowly. It has to do something about my character, because if I'm doing something, I always get enthusiastic, so I started with 15 times, and then within 2 weeks I thought, oh, I can do more maybe, but then you get some problems with your elbows, and don't do that. So this is tip number 1. If you have to start with it, just take it easy, take your time to build things up. Don't go too quickly. And another thing is, and Linda already told it, it's very important that you have someone with you who can correct you, a physiotherapist who can help you. Well, that's, at least it was for me, very important, to be honest, because we had those exercises with the hip adduction, like this, and you had to do it slowly and take time, so you're really using this muscle. And there was a moment, I got enthusiastic again, and I was going like this, and the whole my body was moving, and the physiotherapist, oh, what are you doing? I thought, well, this is maybe better to do it like this. No, it's not. Just slow down, take slow steps. Don't overdo the thing. So, and then you need someone who is correcting that, because you really become sloppy. It's so easy. They explain it to you. But within a few weeks, you think, I don't know what you think, but you're going to do it different than the first times. So that's tip number 2. Make sure that there is someone around you who's knowing how you do the exercises. Another tip I would like to give you also is, it makes it easier if you have other people who are joining you. Because at a certain moment, if you're doing this for 3 months, I always have the same group of people with me. And then you have to bite for 15 minutes, and you don't have anything to do. It's boring. But if you have someone next to you, and you can chat all the time, I think that's even more for women, because we can multitask better. But we bite and we talk, and then the time is going very quickly. So it's making it easier if you do it with someone else, even if you don't feel so well. You know that the other person is waiting for you, so you think, oh, I go. So do it with someone else. Linda was also telling something about results. For me, I don't have all the results yet, but it was correct that I have a better condition. This is one. I feel stronger. I think that's very important too. I can't say that I walk much easier, but I can walk a little bit longer because I have a better condition. I stayed within the CK levels, so I know it's safe for me to do all those exercises. And one of the things I was surprised with was when we were doing those tests in the beginning, the stability exercises that she was showing, the animal was lying on his side, or you can make a bridge when you're lying on your back. You know what I mean with this exercise? Well, when we tried to do this on the first time, before we started the program, I couldn't do it at all. I was just lying there on the ground, and she said, you can start. I said, well, I was starting already, but my butt didn't get from the ground at all. I really had no clue what to do. I told her, there is no connection between my head and my body. I don't know what to do. There is no muscle there, or there is something wrong with the signal. And she said, well, you will wait and see. After 3 months, you can do this. And I was thinking, yeah, sure. Well, we have to see. But she was right. And it doesn't want to say that I will get up from the ground like this. But I get up with making this bridge. I can hold on for a few seconds. And I was really surprised because she said it's just a little bit dusty. It's a little bit rusty. You can do this if you just take the time and exercise and try it again and you will manage it. So I was very happy to see after 3 months that I could make this bridge. on the side, on my back, and all the other stability exercises. After the 3 months, I realized for myself at least that I didn't want to go back to the once in a week physio fitness. On the other hand, 3 times a week, that is pretty much too, because in those 3 months, I hardly had any social life anymore. And as I told you, I'm a busy woman, but I had to stop with a lot of things. But once a week, I think it's not enough to maintain and even improve a little bit. So I did change my life a little bit. I worked 4 times a week, and I now work 3 times a week. I just put the hours into 3 days. It means that I have 2 days off. And those 2 days, I still start very early at 8 o'clock in the morning, and I do the same program because I want to keep where I am at this moment. And I hope that you get the opportunity to do something like this too, because it really gave me at least a very good feeling that I can do something myself actively about keeping my body in a good shape and in a good condition. And it gave me a very good feeling and very confident. Thank you very much.
For this panel, we have even more light. Can't have it lighter. Sorry. Yeah, so we take questions. First question, yes, please.
Question for you, Linda. On the days when the patients were exercising, and those days where there was also ERT administered, was there a paradigm of give ERT first, exercise second, or the other way around? I'm sorry, the broader question I'm trying to get at is, did your study or other studies look at the effect of exercise on overall muscle perfusion on the days that ERT was administered?
No, we don't. We didn't look at that.
Stand up. Stand up. Stand up.
We didn't look. No,
it is a dent now,
We didn't look at that because we want to study the effects of the exercise training pure itself and not on the perfusion during enzyme replacement therapy.
Good. Other questions? Yes, please. Can you please stand up?
Slightly related to that, I don't think.
Not yet.
Slightly related to that, when I originally talked to people about exercise, that's really all that they could. Those were the only kind of things that they could think about, and I kept saying, no, I really just want to exercise them. I don't want to make the drug go in better or whatever, but it really took a long time to get that message across.
Yes, please.
Hi, this question is for Dr. Harrison-Jones. Have you worked with any children infantile Pompe that are trach, and did you use a PMB for that?
I don't believe I've worked with any trach children. Certainly I've worked with children. I don't think a tracheostomy would inhibit that in any way. With some of the things I do, it may make it slightly more complicated. In terms of a passy mirror speaking valve or a one-way speaking valve, I don't think there's any specific contraindication to it, but of course each person needs their own individual assessment. Does the person use a cuff on their trach?
It's not
Uncuffed? They're pretty liable to be a good candidate. I mean, I don't know the person, but uncuffed tracheostomy they can often tolerate a speaking valve. Yes.
Thank you.
Stephanie.
Yeah. Wait a minute. The mic is coming.
There's one question. Wait, here, one over here.
Yeah. Wait a minute. Yeah. Excuse me. We'll take first this one. You'll be next.
Dr. Jones, I just want to say that
at Duke, we do have currently two trach patients that do use the Pasteur valve, and small bits at a time, but they're able to tolerate it. And so hopefully with training, we can build that up to more time. So we have used it.
I didn't do it though.
A question for Dr. Jones. I struggled a little bit with the tongue issue. I've never heard of that as a late onset patient, and the 19 out of 19 that seems pretty 100%. I mean, is it possible it's just as people get older, their tongues get weaker, or I don't.
Not like that.
Really?
No. Of course, these were data obtained from manual muscle testing. We have collected some data using instrumental transducers and are finding very, very similar results. Our tongues do get weaker as we get older, but that would be a lot older and not so weak. 19 out of 19 is a lot, though. You're right.
We had a question at the far left of the room.
Yes, please. For you, like that. Will you make available to us a guideline for an exercise program that we can take our physical therapist or whatever to?
Yeah, that's one of the purposes of this study. So we have to first get all the results, of course, and maybe do some studies in different groups of patients, but we sure want to make a guideline for everybody.
That was my same question. I wanted to find out how a physical therapist could help someone.
We make the guideline, but of course you can always send me an email or an email to our team, and I will gladly to answer your questions.
Our OTs also involved.
Wait a minute. First, wait for the mic. Yeah.
Are OTs also involved in this?
I don't understand your question. What's an OT?
Occupational therapist.
Okay, not in this study, but it can be later.
Another question, yes, please.
Where can we get a copy of the guidelines that you followed? Work with them.
You can send me an email, and if we have all the results, I can give you the guidelines.
And this is that for 1.5 hours, 3 times a week. They build up to that, right? Because there's no way that I'll ever be able to do anything like that.
No, we didn't build up.
I mean, you really put them,
Yeah, even the first weeks it lasted longer than the 1.5 hours, I think, because you have to get used to the exercises and the machines you are doing the exercises on. And later on it gets more easy, and then I think you have to do 1.5 hours. But the 3 times a week was on purpose for the study, so I think when you go into 2 times a week in normal life, you can manage your increase in endurance and muscle strength. So you don't have to train 3 times a week for a long period.
Another question over here.
Yes, we should probably also mention in relation to...
It doesn't work with that microphone.
I have a question about your strength level when you started the exercise program. This is kind of personal, but how impacted were you? I would have to fall on the ground, and it would take me the 2 hours to get up. So how did you manage? I mean, were you pretty healthy when you started this? Yeah. I mean, were you assisted in any way, or how were you able to manage that?
Well, it depends on what your definition is of how healthy you are. But I was a little bit the same like now. So, well, if I fell, I can stand up myself. So that was in the beginning, and that's what I still can do. So in that case, there was not much change. It's just I feel stronger, and I have to say that in function, like do you walk more need or something like that. That's not the truth. I don't feel it yet. Maybe it can come later, but I've got more condition and I feel more stabilized.
So did you have anyone in the program that could not do the exercises?
Yes, we had in the beginning with the core stability exercises, but all the strength exercises and endurance exercises we were able to do. And at the end of the program, everybody could do the core stability exercises.
Can I ask a question? Can I ask a question?
Yes.
Did the exercise hurt ever? Hurt?
The exercises itself, no.
Like when you got home?
No, it's only when I start to think that I know it better, and I do starting things like I shouldn't do, then you overload yourself, you know. So, but if you just stick to the things they tell you, it wasn't a problem for me. No.
But your recommendation was that people have someone sort of guide them along, and I would agree with that really strongly because it's so hard to monitor, and human nature is just, if I can do 10, if I'm supposed to do 10, wouldn't 15 be better? And I don't think that's always the case.
Yeah, that's true.
The remark that I wanted to make, and I hope it was clear, that you took really a group of patients that was in a rather good condition, and patients who were able to ambulate and did not require ventilation during the night. And the next step is to expand the training programs to other groups. So.
Well, I find it very interesting that you, I'm sorry, I'm a little brunette down here, that when you were laying down, you were asked to do the bridge, and you mentioned that your brain wouldn't connect. I thought I was the only person that felt that way. My nephew says, "Oh, Andrew, we should just bend down like this." And I'm thinking, what's wrong with me? It's not connecting. I don't remember how to do these anymore. So I'm glad to hear that there is hope for that.
Yeah, and you can exercise that. I was really surprised by that too, because when she told me you can do this after 3 months, I was really thinking, yeah, sure. But it's just dusty, it's rusty, because she told me that you don't do this. And she had to help me a few times by lifting my hips up, you know, and then suddenly you think, okay, that's where my muscles were. Now I know it a little bit, and then you have to practice.
And what I noticed is that, actually for both Linda and Wilma, I'm not sure who the answer, what I noticed is that over time, the heart rate decreases. Normally I had a heart rate always quite high, and now my normal heart rate is much lower. Is that something you noticed too in your study?
It's a common effect of exercise training, and I haven't the results, but we sure looking at that during the maximal bicycle ergometer test. So, but it's a known parameter of exercise training.
And what will the then say? Because my physical therapist says, well, you now have a sport heart. I never thought I would ever have one, but what does that mean for my physical condition?
It means that your physical condition is better and that you don't have to work that hard to get a certain level of exercise. So at the beginning you have to work very hard to get an exercise done, and now you can do it with less effort. So you can train, or you can train harder, or you can stay at this level.
Because and also what I was wondering, did you see in your study that people reach a limit in what they can exercise?
I think the study is too short for that, but what we see is that you get an increase in effort after the first 4 to 6 weeks. You get an improvement in the strength, and after that, at 10 or 12 weeks, you get an improvement. So we didn't see the plateau at our study, but there sure is a plateau.
Okay, yeah, I noticed it already, because I really have to do my utmost best to get a heart rate of 130, and now my physical disability is limiting me to get that high heart rate.
Yeah, you can try to do another endurance exercise, but I think it's difficult to choose the right one, and we should look at that maybe. Thank you.
Did you see weight loss from this regimen? It seems pretty
I can't tell you anything about it yet, but it's one of the parameters of the study, yes.
I think
I don't have them yet, so.
Okay, we have one more question, and then we go for lunch.
For Dr. Jones. I'm wondering if you're aware of any exercises to improve throat and muscle function. Throat muscle function.
I have some ideas about those things, and it's something that I'm working on right now. Nothing that I feel very comfortable, unveiling or anything like that. Although I think that we have undersold exercise in neuromuscular diseases, I do have concern for harm to still occur as well, and I think things need to be closely studied and carefully monitored. So, I don't have a recipe, as it were, right now, but I hope to someday. Maybe not too far away. We can strengthen the tongue, though. I mean, I don't know about in Pompe disease, but in healthy individuals and in a variety of disease conditions.
Okay, thanks all of you, speakers and the audience. So we have a coffee break, 15 minutes.